pressure. So if you hear blood pressure, what they're talking about is the pressure in the arteries when your heart is constricted or squeezing. That's your systole. And then the pressure in your arteries when your heart is fully at rest. So that's diastole. So systolic pressure is the pressure of your arteries within the arteries while the heart beats. Diastole is the pressure in the arteries during pauses between heartbeats. Okay. So you can see on the left, this heart is squeezing, it's kind of constricted looking, and over here it's just at rest. Okay. And the pulse pressure is the difference between the two. So you would subtract basically your systolic from your diastolic and see how different that pulse pressure is. We have different things that affect blood pressure regulation. So, has anyone heard of vascular resistance? Basically, you have conditions in your body and your blood that will make your heart have a harder or an easier time getting blood out of your heart. Okay. So here with viscosity, if you have thicker blood, viscosity is how thick something is. Okay. So the more viscous your blood is, the harder your heart's going to have to pump. It's kind of like if you were trying to pump a milkshake out of your heart versus water. Okay, your heart's going to have to pump harder to get a milkshake out. So the more viscous your blood is, the more resistance you have, the harder your heart has to pump to get it out. Vessel length, the longer your blood vessel, the more friction and the more resistance. So I think of like, a straw versus a garden hose. If you're trying to pump something through like a garden hose that's longer, you're obviously going to have to pump a lot harder, right? If you're just pumping it through a straw that's a lot shorter, it's going to not have to pump so hard. So the longer the vessel, the more resistance you have, okay? Vessel radius. If you have a wider vessel, it kind of reasons that it has less resistance, right? Your body has more room to pump blood through. If you have a narrow artery, your heart's going to have to pump harder to get all that blood through a narrow artery. Does that kind of make sense? Okay. So, it's influenced by the diameter, the length, and the viscosity. Okay. So y'all just kind of become familiar with this because peripheral vascular resistance can really affect your heart. This is just kind of a little picture, like the heart over here on the left has very low resistance, so it's just like easily pumping blood out of the heart. The heart over here on the right has a lot of resistance, so it is having a hard time getting blood out of the heart. What do we think that might do to your heart over time? Wear it out. Wear it out, yeah. So there's this thing called left ventricular hypertrophy. You probably all learned to flow the blood through the heart this weekend, right? So if your body is trying to get blood out of the heart from the left ventricle, and there's so much pressure down here, your left ventricle is going to get really, really tired. What does hypertrophy mean? It means it like gets really larger and harder and just kind of, it just wears out. It gets thicker, that wall of your left ventricle gets thicker. So we'll talk more about that in just a second. Okay. There are different things that regulate our blood pressure in our body. The first is baroreceptors. We're not talking about this in great detail, but the baroreceptors kind of recognize when you have low blood pressure, and ultimately they vasoconstrict to increase your blood pressure. Okay, they cause your blood vessels to become smaller, so your blood pressure will come up. Okay, what happens when we vasodilate?
Get bigger.
Yeah, they get bigger, and you ultimately get a little, I don't want to say hypotensive, but your blood pressure goes down the more vasodilated you are. Okay. The kidney. Does anybody know about the renin-angiotensin-aldosterone system? It y'all learn that, like, microbiology or anything like that? I don't really expect you to remember, but if you're, if you've heard of it in the past, remember your kidneys secrete this, it's a cascade basically, and Miss Posey is gonna talk to you all a lot more about the renin-angiotensin-aldosterone system. When she teaches you renal, I think it's maybe next week.
Do you need to know this, whatever the test?
Well, you need to know generally, like basically to the depth of this lab, how these mechanisms help regulate blood pressure. And ultimately, they all are causing your blood pressure to come up, okay? We talked about the pituitary gland and how it affects antidiuretic hormone and cortisol. So those two things together will help increase your blood pressure and volume. This increases your blood pressure and volume, and this is causing arterial constriction so that your blood pressure goes up. So really, they're all doing the same thing. It's just how, So that is what helps us regulate our blood pressure and keep us in homeostasis. But Miss Cassie will go into a lot more detail about, I call it RAS, rated angiotensin aldosterone. Okay, y'all answer this question. Yes?
Yes.
It is A, yep, it helps regulate blood pressure. Okay. So what is our blood made of? And we're gonna briefly talk about the arterial wall. So we have of course we have like red blood cells, white blood cells, all those things. We have blood cells in our blood. But what else do we have? We have lipids, glucose. If you use nicotine products, maybe some nicotine. And we all have some degree of free radicals. So these are all things that are in our blood. And but they're not all necessarily bad. Like we need cholesterol. Cholesterol is a big component of cell membrane. It helps with steroid hormones and bile acids. So we need cholesterol, right? Do we need a ton of it or the bad kinds of it? No. So we talked briefly about this. Y'all remember what HDL is? It's your good cholesterol. So high density lipoproteins carry cholesterol away from your arterial wall, which is good. We don't want stuff stuck to our arterial wall, do we? The LDL, low density lipoprotein, it deposits onto the arterial wall, which is problematic. We don't want stuff sticking to our arterial walls. So, if we have too much of these things, like too much glucose, can injure the inside of your artery is endothelium. Okay, so you'll hear me say that term a lot today. There used to be a picture on here with the layers of the artery wall, and I was like, that's gonna overwhelm them, so I took it out. So you basically just need to know that the inside of the artery is made of endothelial tissue, okay? So, too much of any of these things can cause endothelial injury, which is not good for your arteries, okay? You can see free radicals damage the endothelial lining, glucose can damage the endothelial lining, nicotine can increase your heart rate and your blood pressure, which over time can also damage the endothelial lining. Because the more hypertensive you are, that means you've got a lot of force pumping blood through your arteries, and all that force over time can damage that lining, okay? I think that's all I'm gonna say about that. Questions about this stuff?
Can you repeat what the triglycerides do one more time?
Triglycerides? I don't think I really spoke to those specifically. They just are in your body when you eat them, but excess triglycerides can hurt your arterial lining. Okay, yep. So nicotine increases your blood pressure because it causes you to vasoconstrict, squeezes your arteries. So too much of that is not good for our artery lining. gonna start with hyperlipidemia. Some people use these terms interchangeably, but they're not really the same. Hyperlipidemia is just what it sounds like. It is too much. So too much fat can be cholesterol, triglycerides. This lipidemia means you can have something high and something low. So it just basically means your levels are off, but they can be high or low, okay? So that is how they are different. You probably will hear them used interchangeably, but this is just high and this is high or low, okay? So our etiology is usually caused by too much of it through the diet, or liver. Yeah, the liver produces cholesterol, so your liver may be producing too much. There is something called familial hypercholesterolemia, which is just what it sounds like. It is a family genetic predisposition towards this, okay? Because you may have someone who is the absolute picture of health and eats great and exercises and they still have high cholesterol. They're like, I don't get it, you know? So that's kind of what we're talking about with that. And it can predispose you to atherosclerosis, which we're about to talk about a lot, okay? Any questions about these? So the good thing about this system is that generally all of our risk factors for all of these are going to be the same. So that should make y'all happy. And there's a chart coming up that will tell you all about it, okay? But some of our risk factors for hyperlipidemia are low physical activity, sedentary lifestyle, obesity, maybe a diet that is high in saturated fat, trans fat, if you eat a ton of meat and dairy products, like especially red meat, you know, that's just not great for you. If you have certain conditions like diabetes, that can increase lipids in your bloodstream. So we've kind of talked about the underlying cause of this is either you are eating too much of it, your liver is producing too much of it, or your liver is not metabolizing it as it should be. So those are kind of the three things. Too much dietary consumption, too much liver production, or your liver is not breaking it down like it should be, okay? Clinical manifestations, it's often asymptomatic. They may feel like they're having symptoms of heart attack or angina, which those are both really just chest pain. I know Ms. McBride is going to talk to you a lot more about angina tomorrow, okay? But it's either asymptomatic or it can mimic one of these two conditions, which is chest pain, essentially, in a word, okay? Complications, it can lead to atherosclerosis, which we were about to talk about, and ultimately cardiovascular disease. Okay, hypertension. Have y'all learned a value yet? Like when I say hypertension, what values do y'all think of? What numbers? Okay. Okay, well good, that's this morning they were like, oh, like they weren't sure. I was like, have y'all been told in health assessment what number to think of when you hear hypertension? And I don't think that we had like a consensus. So for these purposes, I would think about 140 over 90. Somewhere in this range, 130 to 140 over 80 to 90. I would say that's the safe range, you know. So we don't ever diagnose someone with hypertension after one reading. Y'all are probably all just caffeinated, stressed out, don't want to be here. So if I took your blood pressure, you may have a little hypertension right now. But if you go home and you sleep and you get to rest over the 4 to 12 weekend, your blood pressure will probably go down. And so we get two readings back to back, basically, like a week or two apart before we say you have hypertension. Okay. There are primary causes and secondary causes. Well, really, we do not know why people have hypertension 90 to 95% of the time. It is just unknown. Secondary causes can be something like renal dysfunction or endocrine dysfunction. So, you remember we talked about in the endocrine system, Cushing's disease, and how your adrenal glands are secreting too much cortisol, and that something like that is gonna make you have hypertension. That's a secondary cause. tobacco use, excessive sodium intake, y'all probably knew that about sodium before you even came to nursing school. Stress, excessive alcohol intake, and hypertension is often closely associated with these two things, obesity and diabetes, okay? Of course, when I say diabetes, I'm meaning type 2, okay? For these purposes. Any questions about this so far?
It wouldn't be genetic.
What'd you say?
It wouldn't be genetic.
It can be familial sometimes, yeah. Like my family, I'm pretty much the only person in my family who doesn't have hypertension. My sister started taking blood pressure medicine when she was like 17. Yep,
Hypertension in my family is highly genetic.
really.
My grandmother, she's on 3 medications for hypertension, and her still stays of
Yeah.
50s or 100s.
Yeah, it's pretty crazy. It can definitely be genetic and familial.
Like even mine at my age, it stays at 140s or 90s.
Really? That's crazy. But yeah, when my sister turned 17, I mean, she was very active, like ran, swam, was on the soccer team, she had, and she still takes medicine for it, now she's like 40. So, yeah.
You can't wean yourself off of having hypertension, can you?
I mean, we're gonna kind of touch on that in a second, like, you can change some things about your lifestyle that might improve your blood pressure, but sometimes you can't, like, I would guess in her family's case, you probably can't.
I have been off blood pressure medicine. He was on it since he was in high school, and he just got off after he lost weight.
That's right.
See, like, for example, he has high blood pressure, and one thing he does home is he makes shoes. He's got every morning.
Okay, so yeah, so if you have things, well, we'll get to that in just a second, okay? The Patho, we talked about how 90 to 95% of the time we don't know why. Some believe that it is due to a hypersensitivity to the renin, angiotensin, and aldosterone system we talked about. So sometimes we may have like a hypersensitivity to those hormones and things that are released in your blood that make you over vasoconstrict and it increases your blood pressure too much, okay? You may have an increased sodium sensitivity, so you may retain more water. Those are kind of just some of the things people generally believe are the underlying causes that we don't know for sure. Okay, so the higher your blood pressure, the more pressure it's gonna be on your arterial walls, which leads to that endothelial lining damage we were kind of talking about. You also have some high resistance against your heart's left ventricle. So here's your pretty little left ventricle, but over time, it's gonna start to, this wall is gonna thicken and harden, and it's not gonna function as properly because it's been under so much stress for so long, and it's starting to wear out, okay? So that is what ventricular hypertrophy is, okay? This is just kind of a picture showing you, I think this guy's carotid artery. Y'all remember me talking about that when we talked about strokes, ischemic strokes and stuff like that? But this guy's carotid artery, over time, you see the damage that it has gotten due to his high blood pressure, maybe, a unsafe amount of those substances in his blood that we talked about, like the nicotine, the LDL, the free radicals, all that stuff. Think back to that slide, a few slides ago. So over time, his artery has become damaged, okay? And we're gonna talk about this in just a second. Alright, so your clinical manifestations, y'all probably all heard that hypertension is the silent killer, meaning a lot of the time we don't have any signs and symptoms until it causes organ dysfunction. So, you may know someone personally who has just one day gone to the doctor being like, I just don't feel right. I have started noticing, you know, like maybe if you're married or whatever, maybe you can't have sexual relationships like you want to, that may be a reason you go to the doctor. Maybe you're starting to have chest pain or vision loss, you know, any of these things, it's silent usually, and so they'll go to the doctor once they start having some weird are ready to start getting up, you'll start, kind of like your, I don't know what I'm trying to say, but you have like a lag between your body saying, okay, I need to vasoconstrict just a little bit. We need a little bit of vasoconstriction to stand up. Otherwise, if we're vasodilated, what's gonna happen? You're gonna hit the deck. So your body has this like little delay in realizing, hey, I need to vasoconstrict. I think it's your baroreceptors that don't, they're kind of behind because you've been laying down for an extended period of time. So you will complain of maybe feeling dizzy, feeling faint. You might lose consciousness. That happens sometimes where they pass out. You might get a little sweaty, a little tachycardic. So you take care of a patient. I mean, we have so many patients in the hospital with this. Whether it's like a car wreck and they've been in a coma, or like a gunshot wound, anything where they've been in the bed for a minute. And then PT and OT and nursing try to get them out of bed to like do exercises or go to the bathroom. They will 100% pass out. So I always really try to hold on to them, especially initially when they're getting their feet back under them, so to say. So, yes.
We typically just say, okay, just try to stand up slowly.
I grab onto them really firmly. I like put my leg behind them and hold on. And then, yeah, we tell them to sit up, dangle their legs, kick their legs, because even when they do that, even when they just sit up, they'll start getting dizzy and faint feeling. So once that's kind of stabilized, then they can try to stand. It's like a very slow process, you know.
True, like my mom says this one's called DFO, meaning fell out.
Yeah,
So it's
I've heard that too. So, yeah, questions about orthostatic hypotension? Okay, so when I say sclerosis, really just what I mean is hardening or narrowing of body tissues. So the word sclerosis, that can apply to a lot of different places in your body. But when I say atherosclerosis, I'm really talking about your arteries, okay? So, and I kind of just put this up here to differentiate between these two, but really atherosclerosis is really just a form of arteriosclerosis, okay? They're kind of the same, but I don't want y'all to focus too much on arterio because this is a form of this, okay? Atherosclerosis is a form of arteriosclerosis. So it's really just this gradual process where you have this atherosclerotic plaque that accumulates on an arterial wall that has been damaged. I'm going to show you a lot of this. And it ultimately restricts blood flow. So it can be pretty problematic. I mean, that's just not good. That's not what you want to see, right? You want it to be nice and patent and open and a big diameter. So hyperlipidemia is often the fundamental condition that causes this, and we will talk about why in a second. So it all starts with damage to the endothelial lining, okay? So you can see up here at the top, it says endothelial injury, right? From whatever reason, maybe it's hypertension, maybe it's too many of those bad substances in your blood that we talked about. So you have an injury, that's step one. Step two, we have a buildup of LDL, so the bad cholesterol starts to stick to the lining of your artery at that area of injury, okay? So your damaged area starts to have all this LDL stuck to it. So step one is injury, step two is buildup. Step three is foam. They call it foam because it's white blood cells that start to come, and they think they're helping. You know, we talked about that somewhere. Sometimes your body thinks it's helping, but it kind of ends up doing more bad than good. So these white blood cells come and they think that they're helping, but over time, and that's why they call them foam. It kind of starts to look like white foam, basically. So they kind of start to adhere to this plaque, or they start to adhere to your LDL accumulation. And so over time, together, they form this beautiful plaque, okay? So injury, buildup, foam, and plaque. So the bad thing about the plaque is that it makes your vessel more susceptible to rupture. It decreases the diameter, obviously, for blood flow, so, do y'all remember from earlier on what we said? What does it mean when you have a more narrow diameter? What does it do to your vascular resistance? Yeah, it slows it down, so it increases your vascular resistance. So, you have all this junk in your arteries, and so your body is really not able to pump the blood out to your body as well as it needs to, okay? It also, the plaque can dislodge, like many other things, and cause thrombus, right? We don't want any kind of thrombus or any kind of plaque dislodging in our body. Because that's right here, you can see it says, plaque can break off and travel and make an embolism, okay? So I would say that vessel rupture and embolism are two of these complications, okay? Does that make sense? Hopefully? Okay, now we're getting into our risk factors that you were asking about, yeah. So y'all have learned the difference between modifiable and non-modifiable, right? So the good thing about this chart right here is that it is for all cerebrovascular disease. So that's gonna be everything I'm talking about, a lot of the stuff that Brad talks about. So it would probably be smart to be really familiar with this table and, in the textbook. It is table 15-4. And the table in the textbook just gives a lot more like detail, I guess you'd say. I have put kind of like the abbreviated version up here. But, okay, so modifiable diet, what might we change from our diet?
Red meat.
Yeah, eliminate the lot of meat, like red meat, a lot of dairy products like butter, heavy whipping cream, that kind of stuff. What about physical activity? We can be more physically active, right? By doing these things, maybe we can work on our obesity some. Have y'all learned a BMI that goes along with obesity? What is it? Do y'all remember? Do you remember what number is like correlates to obesity? Like 27? I think it's 30. So that might be overweight. But if you have a BMI of 30 or higher, that is obesity. Tobacco and alcohol use, we can eliminate that. Stress, we can try to eliminate some of that. Whatever, take medicine, whatever. Hypertension, I did add this line here, so if y'all wanna add that, you can. I just added hypertension and diabetes. And is this diabetes type 1 or 2? 2, because we've not modified type 1, right? Right. So I put these question marks because I wanted y'all to know the value of hypertension. So, like we said, about 140 over 90, okay? I'm gonna get a for sure answer on that because somebody was saying 130 over 80, I just don't know. We need to come to a consensus on what this is. If y'all learned 140 over 90, then let's go with that, okay?
What is the number of the chart?
15-4. That's table 15-4. Okay, so non-modifiable, of course, we cannot change our age, right? It's more common in males greater than 45 and females greater than 55 because it's more common in men and postmenopausal women, okay? So it's more common in African Americans, and if you have family history of, we kind of talked about the family history of hypercholesterol and stuff like that, so you can't change that, okay? So, it's a very gradual process, but ultimately it's gonna lead up to you having, hardening just gonna talk about peripheral arterial disease. So, atherosclerosis is the main culprit. It does commonly affect the lower extremities. It obstructs blood flow to the legs. Yeah, there's that table again. See the risk factors? So there it is. Let's see. It is very common in the femoral artery. See this big femoral artery that runs? It's really common to get like a atherosclerotic plaque there, and then you will not have blood flow to this lower extremity, okay? So there is a disruption in blood flow due to decreased vessel diameter. It can lead to ischemia. What is ischemia? Yeah, so like you're having some restricted blood flow, which will then lead to maybe infarction and necrosis. So infarction and necrosis are like your tissue death, okay? So really you have this oxygen demand from the tissues in your legs that can't be met. Like the oxygen supply is less than the demand because there's blockage, okay? We can't get blood down there to oxygenate.
So this mainly happens in the legs?
It's mostly in the legs, yeah. It can happen other places, but it's really common in the lower extremities. Okay. Okay, so clinical manifestations, we usually don't see any until there's about 70% obstruction. So your arterial lumen, when it's like 70% blocked, that's when we'll start seeing some of these things. So we have the 6 Ps. This says 5 Ps, but that's because they look one off. So the first P is pulselessness. So if you feel someone's pulse in your foot and you either can't feel it or it's weak, that is concerning. That's telling you that they're really not getting much blood flow down there, okay? So if you know, by reading your chart, that your patient has peripheral arterial disease, you need to be doing your due diligence and feeling their pulses to make sure that their limbs are being perfused, because if not, you need to let someone know ASAP so that they can do something to try to save that extremity, okay? Have y'all ever had a grade pulse yet? So 0 is absent pulse. 1+ is a little weak, 2+ is normal. Huh? Yeah, 3+ is bounding. So, if you were to feel this and it was like a 0 or a 1, that's concerning, right? So that's kind of where y'all start putting the pieces together, like what you learned in health assessment, you carry over to this type of thing. Like, if we put on a test question like your patient has a 0+ pedal pulse, then that would tell you they're not being perfused, right? So that's where y'all can start like connecting these. So anyway, if they don't have a pulse, that is a critical limb ischemia. It's a medical emergency. You would need to tell someone really quickly so they can try to save their limb before it starts to die, okay? Pain, there is something called intermittent claudication. That is your cramping leg pain that happens a lot with exertion. So if you're up, walking, running, whatever you're doing, you get this really bad, intense cramping leg pain, but then it improves when you sit down. That's kind of what that is, okay? Your pain is also worse when you elevate your legs. Why is that? So if you've already got a narrowed artery and your artery's already trying to pump blood to like your shin, your toes and stuff like that, if you prop your legs up, it's just fighting harder against gravity. So it's working even harder than it already is, okay? So would not elevate the legs in this person, okay? Yeah, pallor, y'all know what pallor is, right? Like paleness. I don't think you've learned capillary refill yet, but, or maybe you have. Okay, so your capillary refill is supposed to be what? Yeah. So, again, in this person with PAD, if you check your capillary refill and it's like 5 seconds, what does that tell you? They're not being perfused well, right? So, paleness, sluggish capillary refill. What about numbness and tingling paralysis, if it's very severe, you'll see where it starts to affect the nerves and they kick. And then poikilothermia, that was a new term for me, but that basically just means coldness in the extremities. So here are your 5 Ps, but add that poikilothermia, which means a cold extremity. Because that makes sense, right? Like when you're perfused, your skin is warm. When you're not perfused, it gets cold, okay?
Wouldn't that be like powder almost?
Pallor?
Yeah, wouldn't that be like the same thing, it's like, okay, it's white, you know it's cold.
So pallor would be the color, but temperature wise, this pertains more to temperature.
Okay.
You know,
So
it
what
would
is
be
PAD
like,
mean, what was that?
where?
The more severe the PAD is.
Oh, so the more severe your peripheral arterial disease, meaning
Okay.
like the more your vessel is occluded, it takes less exertion. So you might just try to like stand up for a second and you might start having some of these symptoms, you know. You might have that intense like pain. When you used to like walk a mile or two, and then you would start feeling it. Okay. So, complications, we talked about critical limb ischemia that would result in loss of your affected extremity. That's obviously a very serious complication. We don't wanna amputate anybody's leg, we don't have to, or foot. And then we can get arterial ulcers. So, we have ischemic wounds that will develop because of lack of blood flow to the extremity. And it does usually affect the lower legs, ankles and toes. It can be, y'all see where it says the wound bed with or without necrotic tissue? I know y'all probably have not learned too much about like wounds and wound beds yet, but this black thing right here, this is called eschar tissue. Y'all will learn more about that later. But basically, this is just, if you were to remove this tissue, the wound bed would be really, really, really pale. Because why?
No blood flow.
Yeah, there's no blood flow. So that is one of the big ways we differentiate between venous ulcers and arterial ulcers, because if you take all this dead tissue right here, underneath would just be really pale because it's not being perfused, okay? And if that wasn't there, this would just kind of look like a punched out wound, okay? That's why it says punched out wound. It's very painful. The surrounding skin is really shiny, really thin and dry, cool to the touch, because again, it's not being perfused well, so it's gonna be kind of cold. And that skin is starting to, I don't wanna say die, but it's thinner and shinier, it's just not, it's good, healthy tissue that it used to be, okay? When it had good perfusing. Okay, so putting it all together, we have our arterial wall damage. What part of the arterial wall? The endothelium, yeah, so it is the inside. And that is damaged by these things: hypertension, diabetes, hyperlipidemia, maybe nicotine, maybe free radicals, too much cholesterol, all those things that we talked about that would damage your arterial wall, okay? Then you form this atherosclerotic plaque. That is very much influenced by hyperlipidemia, especially LDL. And then you get this umbrella term, cardiovascular disease, which encompasses these two things. So, of course, I've talked about this. Ms. McBride will talk about this tomorrow, okay? Okay. sometimes it might help you to think through with you having a question like this on a test, like ask yourself, what are these things? And then you can hopefully cross through some of them, you know? Yep, there's A. And you may be thinking, well, it does lead to these things, and it does to some extent, but it starts with damage to the endothelial lining from hypertension, okay? And then over time, we start to get the other things, okay? All that fun stuff. Okay, we kind of talked about aneurysm a little bit in the neuro lecture. So y'all remember it is weakening in the arterial wall that will cause a localized bulging and dilation. So it does create this little outpouch that is susceptible to rupture, and your typical sites are your cerebral arteries. Y'all might remember from that lecture the picture of the cerebral arteries in the brain. Or abdominal aortic aneurysm is really one of the most common places. So the wall continues to grow weaker over time. Hypertension is this constant force that's beating down your arterial wall integrity. So you just get this weakened balloon basically. And of course we know it can rupture, right? Because that's what causes hemorrhagic stroke in the brain. In the abdomen, what are you gonna have in the abdomen? Just internal bleeding, right? Which is not in your blood vessels, it's blood that is in your, anywhere but your blood vessel. Because once it ruptures, it's leaving your blood vessel, right? Okay. So, we know that it is typically the result of damage to the arterial lining from arteriosclerosis, atherosclerosis. It can be caused by different degenerative vascular diseases, infection, or trauma. So, you know, if you were like in some sort of terrible accident, you could get trauma that could injure your arterial wall and cause something like this. But usually it is caused by arteriosclerosis, okay? So, again, down here, there it is, smoking and hypertension, they all kind of go hand in hand, okay? These risk factors. Clinical manifestations will depend on the size, the location of the aneurysm, and the integrity, meaning like how weak is it exactly. So 75% of your aneurysms they go untreated until it ruptures, which is a scary thing about. But if you know pressurized blood flow, and then you've got this tear in your aorta lining, okay? And then it actually extends into the next layer of the aorta. The tear gets worse, okay? And then blood can start to accumulate right here. And then, of course, we know it can rupture, which is not great. So, splitting of the layers of the arterial wall results in a tear in your arterial lining. So, it can be caused by hypertension, arteriosclerosis, genetics. Your patient will probably complain of sudden severe pain in their chest. It might feel like something is ripping or tearing. And this, I told the last class, this doesn't really make sense to me, hypertension. Maybe they get hypertensive before it bursts because they're like, something's not right. I've got this sensation like something's ripping or tearing in my abdomen. So they might get a little hypertensive before they start to bleed out. Does that make sense? Okay. If it ruptures, they're gonna quickly lose all their blood volume. And of course, it would be a medical emergency, okay? Here is this video. This video is a little more detailed than I want you to know, but I think it's pretty user-friendly. If you watch this at home, I would stop it at the 2:35 mark, 2 minutes, 35 seconds. Because after that, it gets kind of into the weeds.
The aorta is the largest artery in your body. Your heart pumps fresh oxygenated blood through your aorta to deliver oxygen and nutrients to all your organs and tissues. Your aorta is divided into two main sections, the thoracic aorta and the abdominal aorta. The thoracic aorta has four parts: the aortic root, ascending aorta, aortic arch, and descending aorta. The wall of your aorta is composed of three layers that give it strength: the intima, or inner layer, the media, or middle layer, and the adventitia, or outer layer. The elastic muscular media prevents your blood pressure from rupturing the wall. Over time, degenerative disease may cause the medial layer to break down, weakening the wall of your aorta. Blood pumping against the weakened area may cause it to bulge outward like a balloon. When this condition occurs in your chest, it is called a thoracic aortic aneurysm. These aneurysms may occur in one of several places, including the aortic root, the ascending aorta, or the descending aorta. Blood pumping against weakened aortic walls can lead to another life-threatening condition called aortic dissection, which may or may not occur within an aneurysm. Most commonly, aortic dissection begins with damage to the intima layer. Blood moves through the break in the intima, separating it from the media, causing bleeding inside the wall of your aorta. As a result, a flap called a septum forms between the true aortic channel and the false channel. From here, the blood may break through the outer layer of the aortic wall, causing an immediate life-threatening condition, or it may re-enter the aorta through another tear in the intima. Over time, a blood clot may form in the false channel.
Okay, that's enough. But hopefully that gave you kind of a good visualization of what we talked about. Okay, Raynaud's, does anybody know what this is or have this? When I was in nursing school, I used to run a lot, and my code would get this, and we'll talk about that. So, it's basically a vasospasm of your arterioles, so like the little bitty arteries it starts out with blanching usually. When I say blanching, I mean they turn white. Really, really, really white. We're gonna look at a picture. Once once you have this vasoconstriction that cuts off the blood flow to your fingers and toes, you will have some cyanosis. At that point, your tissues are oxygen deprived, so your toes will turn from white to blue. It can be your fingers too. It actually is more common in fingers, okay? So your fingers or toes will turn from white to blue. But then once the vasospasm resolves and you do start to have some blood flow to your fingers and toes again, they're gonna get really, really red because now they're hyper-perfusing, they're like full of blood, okay? So that's kind of what rubor means. And as you can imagine, it's not very comfortable. Like, imagine tying a really tight tourniquet around your arm for a long time, and then once you take it off, having all that blood rush back into your hand, it's kind of painful. So it'll give you like some throbbing pain, some tingling sensations, okay? We don't really know the cause, but we think it's caused by, like, it's precipitated by cold or extreme stress. So, yeah. Ooh, here's a picture. So first, you have this vasospasm, vasoconstriction, your fingers are not perfused at all. They start to become a little ischemic, a little hypoxic, and turn blue. And then once the vasospasm is over, they will get like really, really red, okay? And this is kind of what it looks like in real life, okay? And these symptoms do resolve on their own. I don't really know anyone who's been treated for this. I mean, there may be some cases where they are, but typically this is self-limiting and it just resolves on its own. Somebody in the class said that, didn't they?
It's gonna be C, right?
Huh?
It'll be C.
C, yes. Okay, so keep in mind that with Raynaud's, it's typically bilateral, okay? So here it says the client has pain in their left lower extremity with exercise. What is that called? Yes, intermittent claudication. So when you rest, the pain improves, right? They have a diminished pulse in the foot. That's one of those 6 P's, isn't it? 6 P's with peripheral arterial disease. Okay, so they're likely experiencing this PAD, okay? What else makes PAD worse? Putting your leg up or down? Up, okay, good. Good job. Okay, we're gonna quickly talk about venous disorders, okay? These are them. So with the venous system, just a quick review, it is a thin-walled, flexible vessel. It takes blood back to the heart. It is very low pressure. That's why we don't talk about, that's why when we talk about blood pressure, it's in terms of the artery, not the veins. Basically, the veins are pretty passive and they just receive blood and keep it going in one direction with the valves, right? So they're present to prevent retrograde, which is backflow of blood in the wrong direction. So y'all have already talked about DVT some. Was that on your test today? Somebody was trying to talk to me about this, okay? Okay, well, deep vein thrombosis is a very, very common disorder. We see it tons in the hospital. So it's a thrombus that develops in a deep vein accompanied by inflammation. When I say deep vein, it's usually a big, big vein that runs near like a major artery. So we talked earlier major commercials, like heart control commercials, where it's like, if you're over 50 and you're a smoker and you take heart control pills, it'll increase your risk for stroke. Does anybody know what I'm talking about? Okay. So high estrogen can be a risk factor here too. And smoking. So you have these three things. You have the pooling and stasis of blood that's forming a clot. You have this vessel injury that is worsening. You're having your platelets are sticking together and forming an additional clot. And you're just hypercoagulable for any of these reasons, okay? So this is what you call Virchow's triad. These three things will really put a patient at risk for DVT, okay? This is kind of a side note. VTE, venous thromboembolism, that is also an umbrella term that kind of houses both of these. So DVT, of course, is still in the deep vein. PE means it has gone to your lungs, right? So if you hear anyone say, or if you read it in a patient's chart, VTE, that's just an umbrella term, meaning they've had a clot in a deep vein, but they don't specify where it is. Does that kind of make sense? Hopefully. So this is, okay, again, for the thrombus develops in your deep vein at an area of inflammation. It commonly develops at the hip, kneecap. Don't know why that says pelvic extremity. I guess that means your upper leg. And it is less common in your upper extremities, but it does happen in the upper extremities, especially if you have, y'all know what a pipeline is, like generally, it's a IV, a really deep IV that goes to your heart. And they'll put them in the arm a lot. Those can put you at risk for a DVT in your upper extremity, so that kind of thing. You might be asymptomatic, but the worse it gets, you're gonna start to see cramping, swelling, tenderness, erythema along the course of the vein. So if I was a betting person, I would say that this is probably an anterior tibial DVT. Okay, tibial, because it's really red, really swollen right here on the right part of the shin. It's hot, it gets warm or hot. So one of the ways that we identify this in the hospital, we will literally take a tape measure, measure the circumference of this leg, measure the circumference of that leg, and it's usually pretty shocking, the difference between the two. That tells you exactly how swollen it is, okay? And also, it looks starkly different than the other one, right? It's really red, it's really swollen, it is warm to the touch. The other leg is like normal skin temperature. So those are kind of how you note those big differences between the two extremities, okay? And of course, we know that a DVT can break off and go to the lungs. Homan sign. Homan sign is when you point your toes up towards your face, like if you dorsiflex your foot, point your toes up towards your face. If they have really bad calf pain, like, yeah, calf pain when you point your toes up, that would be a positive Homan sign, which is one clinical manifestation. So if you get dyspnea, chest pain, tachycardia, hemoptysis, we know means pumping up blood, right? Hypotension or syncope, those are concerning for PD. Okay. Video coming up. So basically, here's your normal leg veins, deep leg veins. Normal blood flow. With a DVT, you start to get this aggregation of blood cells, and they can break off, forming an embolus. And if it goes to your pulmonary system, it's a pulmonary embolus. Okay? Because I know y'all learned the flow of the blood through the heart, so where it comes back to the right atrium from the inferior vena cava, does that sound right? Superior inferior vena cava to the right atrium. Where does that take it though? That goes to the lungs, right? That kind of makes sense. So if you think about it, its destination is the lungs. That's where it's going, okay?
A deep vein thrombosis frequently develops behind the venous valves and may obstruct the blood flow very considerably. In DVT, there's the potential danger of a blood clot breaking free and travelling with the bloodstream. It can be transported over long distances along the large veins of the body. As a consequence, the clot is able to reach the heart. From here, it can be transported into the arteries of the lungs. The clot has travelled through rather large blood vessels for most of its journey, but the vessels in the lungs are much smaller in size, as they branch and divide to cover the large surface area of each lung needed to capture life-giving oxygen. The clot may become stuck in these smaller vessels. A blood vessel in the lung with a blood clot lodged in it is known as a pulmonary embolism, or PE. Although PEs may occur less frequently than a DVT, they can be fatal if not identified and treated promptly. The most common sign of a PE is shortness of breath. However, symptoms may include some or all of the following: pain in the chest, especially when taking a deep breath or with a cough, coughing up blood, fast heart rate, fast breathing. If you had
Just a little fun here. All right, we're going to talk about varicose veins now. This is where you have pressure on your valves over time that causes valvular damage, because those valves are damaged. And they're incompetent, meaning they're not allowing the blood to get back to the heart. So they're abnormally dilated superficial veins. These are not the deep veins we've been talking about. These are the ones that like you can see, well, not in your arms, but usually in your legs. Y'all probably seen people with varicose veins. So it does often look like this. The superficial veins, the valves are damaged, the blood's pooling, they're really pulling onto a lot of blood in those superficial veins. So it can be worse with prolonged standing, prolonged sitting actually, obesity, because the lovely uterus is blocking venous return. So that's why in pregnant women, you'll see this sometimes, the uterus is not letting blood get back to the heart. It's too big. Pressure on your valves, of course, results in damage. As the valves are damaged, they are not able to prevent backflow of blood. So you just got all this accumulation of blood in these vessels, superficial vessels that you can see, okay? Chronic venous insufficiency. So here we are talking again about deep veins, okay? Because you don't really see the veins on the surface, do you, that we can look at. This looks very different than this. Okay, so when we talk about chronic venous insufficiency, this is really your deeper veins. So your valves are damaged, and they cause impaired venous return. So you have a lot of pooling and a lot of stasis of blood in the lower extremities that will cause edema. So the valves of the deep vein valves are damaged, causing venous insufficiency. Here are some of the things that can cause that damage: trauma, obesity, pregnancy, prolonged standing. Okay. All right. Clinical manifestations: you may have thin, shiny skin in this area, just due to circulation issues. Your skin tissue is not good and healthy like it was before. Dust, heat, discoloration, edema, swelling after standing, poor healing, which we'll talk about, heaviness or dull ache in your legs. Like, you can just imagine this probably doesn't feel very good, you know. They might have some cramping, some itching, spiderings. So a big complication that we're going to talk about is venous ulcers, okay? Okay, so venous ulcers, these are also called venous stasis ulcers because the blood is staying in the lower extremities. So for whatever reason you get a wound, like if you were to have this condition, shaving your legs, maybe you hit your leg on a trailer hitch, I don't know. You get a wound, and then because of your poor perfusion, like you're not taking blood away from that area, the wound really, really hard time healing. You have sluggish circulation, poor tissue oxygenation. You cannot remove the waste products that you need to remove to let your wound heal. So really, it just kind of gets worse and worse and worse. So even a simple little wound, if you have chronic venous insufficiency, can become really serious. You can have a bad ulcer, okay? So once your skin breakdown occurs, your tissue is trying to heal, but it really doesn't have the environment to heal that it needs. So it just gets worse, it just becomes an ulcer, okay? This is kind of what it looks like. You can see that the wound bed is really kind of like a dark or a red, what did we say that arterial was? We said it was pale because it's not being perfused, right? These wound beds are really, really red, so that's one of the big differentiating things between them. A lot of them are located medially just over the ankle bone of the lower leg. So you can see they kind of have irregular borders, especially this one. This kind of looks like an 8, I don't know. They have a lot of edema, a lot of drainage. But what does this tell you? Normal pulses and normal cap refill. What does that tell you? It's being perfused, right? It's being perfused well, so it's not an arterial problem, right? So that's another way that we distinguish between the two. That makes sense? Okay. Okay, this is 3 answer choices. Do y'all want to say what the first one is? B, vessel wall injury. The second one is D, hypercoagulability. And E, yep, so E would be your stasis of blood. Those are the 3 things that make up Birchall's triad and make you at risk for DVT. Okay.